I'm one of the two co-chairs of the Practice and Policy Interest Group of ISAM. The new co-chair who works alongside me is Jenna Butner. You can see her on the window up there. And I would like to welcome you all in this webinar. It has been 2 years since the last PPIG webinar. We had a series of those during the first and second wave of the pandemic. So it has been 2 years. And the questions we were asking ourselves were why this topic and why now? So we'll try to answer those. Why now? We know that the pandemic has exaggerated pre-existing challenges and problems in the population we serve and in the service that we offer to people. We also know from history that following times of or protracted times of social crisis like the pandemic, there is always the risk of polarization or politicalization of views. And therefore, we thought that it is important with this webinar to reapproach and try to find the common ground. What is the scientific evidence? What is that brings us all together rather than separate us apart? And we have chosen this particular date because it is close to the 26th of June, which is the International Day Against Drug Use and Illicit Trafficking. And we just wanted to say that, just to remind all of us that the International Day is not against people who are using drugs, actually for people who are using drugs, is a day where we need to remind ourselves of the principles of the international policy, which is a balanced approach between supply reduction and demand reduction. Also within the demand reduction field, which is what we do as professionals, it is very important to remind ourselves about evidence-based provision of prevention, harm minimization, treatment, and social reintegration. And it is that particular angle that we want to use here is what is the evidence that might support or do not support any polarization between abstinence-orientated or harm reduction services. And before I give the floor to Jenna, I would like to remind you also that the International Day Against Drug Use and Illicit Trafficking is a day for all of us to consider the stigma and bring on the surface and discuss and promote the fight against stigma that people who are using drugs facing every day, as well as stigma that professionals who are working in the field might face every day in their working practice. And with that final comment for stigma, I will ask Jenna to take the floor and introduce the authors, and then Panian also will give us some technicalities, some technical advice. Thank you very much for your attention. Jenna.
Great, thank you, Christos, and good morning, everyone. Thank you so much for joining us here. I'm very excited and honored to be a part of this alongside with Christos in the Practice and Policy Interest Group. And pretty much as Christos said, the main reason why we are doing this webinar is to really take a look at the polarization between this abstinence-based and harm reduction based approach to treatment. And I think in the wake of the pandemic, things have, priorities have shifted. And I think it's a really important concept to look at why we are so polarized as a community and as a society. So with that, we have a lineup of some really interesting and wonderful speakers today. So just to give everyone a kind of rundown of the webinar itself. So our first speaker will be Marc Potenza, who will give us a talk on the historical and current perspectives on abstinence and harm reduction in addiction medicine. From there, we will have Nico Clark from Australia talking about injection room service as an example of harm reduction, supporting people to achieve abstinence if that is their goal, often through long-acting buprenorphine treatment. Then we will hear from Sotiris Lainis in Greece, and he will talk about creating a bridge from opioid substitution therapy to an abstinent program. And we'll talk about experiences from an ongoing psychosocial intervention by self-help promotion programs in Greece. And that will be followed by two speakers, Parnian Rafi and Hossein Mohadis Ardabili from Iran. And they will talk about abstinence versus harm reduction approach in managing opioid use disorders and perspectives from early career addiction medicine practitioners in Iran. So with that, I will have Parnian just give a few housekeeping rules, and then we will jump right into the first speaker. And then at the end, when everyone is done, we'll have some time hopefully to have a discussion and Q&A session with all the speakers involved. So Parnian.
Yeah, thank you so much, Jenna. So hi, everyone, and welcome to this interesting event. So just before starting the talks officially, I just wanted to give you some housekeeping notes to just bear in mind. So this meeting will be entirely video recorded and may be shared publicly on ISAM YouTube channel and social media. So if for any reason you wish not to be in the recorded video, you may want to keep your webcam off during the Q&A. That you can turn your webcam on. So please make sure that you're keeping your microphone muted during the meeting, even speakers are giving their presentations. At the end of the meeting, we'll have a Q&A session for about 20 to 30 minutes. We kindly advise you to use the raise hand button if you have any questions or comments that you want to share with us. Of the Zoom chat space. So during the whole webinar, you can use the chat space to share your comments and questions for the speakers. Just make sure that you're choosing everyone as the recipient and not just the organizers. So okay, so I hope you enjoyed the webinar, and just in case of any technical issues with anything, you can also send me a direct message and
Seems that we've lost Parnian.
Oh, you're back.
All right, there you are. Okay.
Oh, sorry. So I didn't know. So I'm sorry. So where should I just start from? Did you miss all of those?
No, just the last.
So just yeah. So enjoy the webinar, and in case of facing any technical issues, if I didn't have any technical issues, send me a direct message, and I'll try to help you solve the problem. Thank you.
Wonderful. Thank you, Parnian. All right. So our first speaker, Dr. Marc Potenza. Director, Division on Addictions Research at Yale, among many other incredible leads, will talk to us today on the historical and current perspectives on abstinence and harm reduction in addiction medicine. So with that, Marc, the floor is all yours, Dr. Potenza.
Thank you very much. Thank you for having me here. And I'm just going to start the slide presentation, and I'll be talking today, largely taking a historical view on abstinence and harm reduction with a particular focus on US history, but hopefully it will resonate with other places around the world. So I have a series of disclosures with respect to gambling, gaming, legal and pharmaceutical entities. And I thought I'd start with thinking about how the term addiction has been used historically. It's derived from a Latin word meaning bound to or enslaved by, and in its original usage, it was not linked to substance use behaviors. However, over time, going back 400 or so years, it became linked to excessive and interfering patterns of alcohol use, and then later to excessive and interfering patterns of drug use. And I would argue that the focus or the conceptualization within a social framework has also been changing. So if we go back 100 to 200 years ago, there are questions of whether addictive behaviors represented engaging in sinful or other vice-like behaviors, or whether they were entertainment or some other aspect. But I think this aspect of morality linked to addiction is important to note. And going back to the late 1800s, these are several books I have in my library. One's entitled Social Abomination, and the other one, Social Dynamite, or the Wickedness of Modern Society. And in these books, they detail, largely from a moralistic framework, engagement in substance use behaviors, as well as gambling and other potentially moral failure type of behaviors. Now, other periodicals at the time, like Puck magazine, which was a satirical social commentary magazine that had these lovely centerfolds, also commented on the complexities of addiction. And this is a miner heading out west with his silent partners around him like vultures or birds of prey. And on these birds are listed things like gambling den, dance house keeper, dive keeper, and opium joint. So the idea that there may be vulnerable individuals as well as other individuals who may take advantage of that was within the framework of the time. Also within the framework of the time was the introduction of a number of pharmaceuticals, including drugs that were not controlled at the time, like opium, that in the 1800s in the United States were used for a variety of purposes, including for calming infants. And status post the US Civil War, there was the introduction of pain-killing medications and spread of opium, morphine, and then later heroin after it was introduced by Bayer Pharmaceuticals. And during this time, the United States was facing an opioid epidemic. So if one looks at a history of that time, it was estimated that in the late 1800s, about 1 in 200 individuals had an opiate addiction, and that data from prescriptions in Boston in the late 1800s suggested that 15% of prescriptions were opiates. And in this setting, there were the opening of narcotic clinics that provided legal provision, dispensing, and use of opiates. However, going back slightly over 100 years ago, the Harrison Act was passed that was meant to regulate opioids and coca. And part of that act was interpreted to prohibit the use of narcotics for treating people with addictions. So this led to about 25,000 indictments of physicians, 10% of whom were imprisoned. And by 1923, all of the narcotics clinics were closed. Now, at the same time, in the late 1800s and into the early 20th century, there were also regulations about drinking, particularly on Sunday. And this also from Puck magazine shows a way out of the Sunday difficulty where this kegometer would dispense beer to willing individuals. There was also around the same time a saloon balloon that allowed people to get over the prohibition law. One can see this out of the limits balloon allowing people to drink outside of the jurisdiction of the police. And this prohibition movement gained ground or momentum such that it became a national law in the United States in 1919. However, it only lasted less than 15 years, given bootlegging, hoarding of old supplies of alcohol, speakeasies where one could obtain alcohol illegally. Prohibition did not work in the United States. And in this setting, other abstinence-focused interventions developed. Most notably, Alcoholics Anonymous was founded in the mid to late 30s. And this has at its core a number of features. So the first step involving admitting being powerless over alcohol, and that as such life has become unmanageable. And this, in a way, empowers individuals to commit to abstinence. And later steps involve other aspects of taking personal responsibility, including admitting faults through fearless moral inventories and making amends to those harmed. And so while this moral framework of the 12 steps in abstinence-based living can be life-changing and life-saving for individuals with addictions, the approach may also generate shame and stigma. And this shame and stigma may lead to low self-esteem, generate stress, and promote further engagement in substance use and addictive behaviors. Now, in the 20th century, there are also changes as to how mental health conditions were defined and understood. And during this time, the Diagnostic and Statistical Manual was introduced. And in early editions, the substance use disorders were either not included or were considered secondary diagnoses to other primary diagnoses. And it was only in 1980 in DSM-3 where substance use disorders were introduced on their own as potentially primary conditions. We should also note that the US was struggling with substance use behaviors on a social level, particularly in the late 1960s. And during the Vietnam War, a number of the troops were using substances such that there was significant concern that when they were returning to the United States, there would be worsening of a drug use epidemic, particularly with respect to opioids. And so this in part led to the foundation of NIDA in the early 70s. And this was based on bipartisan efforts at the time. And this balanced the traditional focus on supply reduction, which was predominantly through law enforcement, with a newer focus on demand reduction that involved prevention, treatment, and research. Also, this played out in the media at the time. So this, the government had reached out to two of the comic book companies, Marvel and DC, to cover the dangers of drug use. And this issue of Spider-Man, which was not approved by the Comic Code Authority because it dealt with the use of hallucinogenic drugs, where the only indication on the cover was this last fatal trip mention, covered the dangers of drug use. However, DC later in the year covered drug use, and perhaps in a more explicit way on the cover, where one of the characters was injecting IV drugs, and the follow-up issue included a syringe and stated that drugs were more deadly than the atom bomb. And interestingly enough, these were approved by the Comic Code Authority. Around the same time, perhaps a little earlier, was when methadone was being discovered and investigated. And Mary Jean Creek, here interviewed for the 50th anniversary of the methadone discovery, described some of her experiences at the time. And she noted that the story of methadone had been long closely tied to stigmas associated with drug addictions. So in the 1960s, many people viewed addictions as criminal behaviors due to weak self-control or personality disorder, consistent with this secondary disorder notion. And she noted that, despite other medications generating physical dependence, such as cardiovascular drugs at the time, like beta blockers, there wasn't the same stigma associated with use of these medications as there was with the use of a replacement or with the use of methadone. Also, Herb Kleber, who founded the Division of Addictions Research at Yale and later became the head of ONDCP, or the drug czar in the United States, he described experiences with methadone on the 40th anniversary. And he noted that at the time of the introduction of methadone, psychosocial program advocates opposed methadone maintenance as likely to reduce concerns about poverty and social ills. One director of therapeutic community sarcastically commented, "I think methadone is a great idea. We should give money to bank robbers, women to rapists, and methadone to addicts." So this reflects, even within the treatment community, some of the negative views towards methadone at the time. Since that time, data have been gathered that indicate that the methadone treatment is associated with many positive outcomes, including in occupational, social, relational, medical domains, among others. So how is harm reduction currently defined? So if we go to the SAMHSA website, the Substance Abuse and Mental Health Services Administration, their description states that harm reduction is an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve the physical, mental, and social well-being of those served, and offer low threshold options for accessing substance use disorder treatment and other healthcare services. And they give a number of examples of harm reduction services that they would like to promote, including those relating to reversing overdoses, as well as targeting the prevention of sexually transmitted infections or ones that may be transmitted via IV drug use. So they also describe specific supplies relating to these efforts with respect to overdoses, safe injection materials, safe sex materials, as well as smoking materials and testing for diseases, as well as providing educational information to people, either through, in this case, written educational materials, but also on their website. So additionally, the Biden-Harris administration is promoting harm reduction through providing SAMHSA with additional funds that they are targeting towards grants to help support harm reduction efforts in the United States. Nonetheless, addictions remain among the costliest disorders to society, and it's estimated that in the US, they cost society over $700 billion annually. And the demand reduction approaches that NIDA and other groups have been investigating and SAMHSA has been supporting are very cost effective, with estimated savings at about up to a 12-to-1 ratio. But as Christos mentioned earlier in the introduction, stigma, and particularly internalized self-stigma, constitutes a barrier to treatment seeking and has been linked to poor treatment outcomes in addictions. So both NIH, as well as leaders of some of the institutes at NIH, NIDA, NIMH, and NIAAA have targeted reducing stigma associated with addictions, including through the use of person-centered language. So how is addiction currently defined, since the definition has changed over time? If we go to Webster's dictionary, it's defined as a compulsive, chronic, physiological or psychological need for a habit-forming substance, behavior, or activity having harmful physical, psychological, or social effects, and typically causing well-defined symptoms upon withdrawal or abstinence. And some of the examples include both substances as well as behaviors. And I think that this is important to note, as it's only been within the early part of this millennium where people have been more open to considering whether behavioral addictions exist. And then in the past decade or so, the DSM, as well as the International Classification of Diseases, reclassifying, for example, gambling disorder as a behavioral addiction. And I think with respect to abstinence and harm reduction, there are both similar and unique considerations for gambling disorder as compared to substance use disorder. Like with substance use disorder, GA has been long in existence and focuses on abstinence, but there are questions about whether participation, for example, in some forms of gambling, like lottery gambling, which may not be as problematic for some people as compared to a primary form that brings them into treatment, such as electronic gambling machines or slot machines. Would gambling on the lottery then be considered a relapse or harm reduction or something else? And I think as we move more into a digital technology phase, and this has been accelerated by COVID, I would argue, we should be thinking about potentially addictive behaviors on the internet as compared to in real life. And the ICD-11 does designate specifiers for online versus offline behaviors for gambling and gaming disorder, but a wider range of behaviors may need to be considered as time moves forward. So in conclusion, I would argue that historically, the conceptualizations and definitions of addiction have changed over time. Views of addictions as moral failings have likely influenced interventions at policy, prevention, and treatment levels. And despite opposition historically and currently, harm reduction approaches have empirical support and are being implemented. And I would argue that behavioral addictions have both shared and unique considerations with respect to both abstinence and harm reduction. So I'd like to thank the organizers, thank funding agencies, and thank you all for your attention.
Thank you so much, Dr. Potenza. That was really fascinating and really interesting perspective on the history of use disorders and gambling and what have you. So thank you. Next up, we have Dr. Nico Clark, who is the Director of Addiction Medicine Service at the Royal Melbourne Hospital and Northwestern Mental Health. He is Medical Director of the Medically Supervised Injecting Room in North Richmond Community Health and a Clinical Associate Professor at the University of Adelaide, and he will share with us his project in harm reduction and supervised injection facilities. So with that, Nico, the floor is all yours. And if you'd like to share your screen.
Thanks, Jenna. How's that? Do you see that? So, hello, everyone. Thanks for the opportunity to talk to you today. I'm talking to you from Melbourne in Australia, from the lands traditionally owned by the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to their elders, past and present. So I wanted to share our experience of both harm reduction and kind of abstinence support in the medically supervised injecting room that I run, and really showing that from our perspective, there's really a blurring these two, and that many of the same approaches that we use to harm reduction are actually the same approaches that support abstinence in this population. And so if you're not familiar with it, this is the kind of center of the heroin market, close to the injecting room where I work. It's the biggest open heroin market in Australia. It's so it's otherwise a kind of shopping, a street with lots of traditional Vietnamese shops. So a lot of eating areas, and traditionally had quite a lot of foot traffic. But like many areas, these kind of shopping districts are kind of struggling now as kind of Uber Eats has taken over, and kind of shopping malls and online shopping has increased. So it's also located in what's Melbourne's biggest public housing estate. So you can see those large high-rise buildings, and then they're also surrounded by a number of low-rise public housing developments. And then the community health centre, which the injecting room is based, is that green circular building right in the middle of that. And it was you can see there from this map of overdoses in 2017 as to why this site was chosen for it to be a kind of a drug consumption facility. That building there in the foreground is a kind of purpose-built what's called the medically supervised injecting room. It's inside, you can see it obviously has spaces for people to inject, but it also has spaces for people to kind of hang around after they've used the facility. And in red, it has an on-site kind of consulting clinic. So this is addition to the kind of obviously the health services which are available in the community health centre next door, and it's really an opportunity to provide a range of health and social support services on the spot, immediately after people have used the injecting room, if necessary, or also kind of with the same staff who the clients have built a relationship with. After 3 years of operating, we'd had more than 250,000 visits to the facility, and almost 5,000 overdoses managed on site, or safely managed. Only 1% of them needed to be sent to hospital, and approximately 6,000 separate people used the service. And you can see we've provided a large number of kind of services in addition to kind of people coming and using the centre to injecting. And if you just to look at that over time, we were once that building that I pointed out opened after about 12 months in a temporary facility, and then the number of visits a day was an average of about 330, and then it's reduced somewhat during the COVID period. So it's a busy service. There are a lot of people who are coming in and out. Who uses the service? They're typically the average age is 42. The mean age of injection was 16, and in some cases it's been much lower. 3/4 are male, and 15% identify as Indigenous, which is much higher than the population rate of 1%. And about 1/3 homeless or unstably housed. And the vast majority have been in and out of prison. In fact, 1/4 have been in prison in the last 3 months prior to their registration for the service. And the vast majority have histories of early childhood trauma, whether it's sexual abuse, with kind of witnessing violence, childhood neglect, and it's often intergenerational trauma. Having said that, we also have a large number of people who in fact don't even use on a daily basis. There are, the number of people who kind of don't fit, if you like, the traditional models of kind of dependent daily use, despite the fact that the vast majority of people are using heroin when they use the facility. And they have a high kind of urgent healthcare utilization. A high percentage of kind of been treated for mental health issues in the past. They use hospital emergency departments frequently, and they've also had high rates of hospitalization. So, and if you look at the drugs they're using, it's almost exclusively heroin, because it's a heroin market. So more than 90% of visits to the room are to use heroin, and up to maybe 5% to use methamphetamine. If you look at why people use a facility like this, what people share when they leave comments is that they value the non-judgmental way that they interact with the staff, that it's a space where they don't feel judged, and for many it's like the one space during the day when they don't feel like they're being kind of regarded by people who are kind of criticizing them and judging them, and how this means a lot to them, just to kind of be in a place where they're not being criticized for who they are or what they do on a minute by hour by hour basis to get through the day. And they talk a lot about how the friendly staff is kind of, they really feel supported by the interactions they have with the staff, and that it's a place where they don't feel judged. That's the overwhelming feedback from the people about why they come to the room. And that's more so than because they're particularly concerned about the risk of dying from heroin use. But they really do, they kind of, we get many positive kind of feedbacks from the clients saying how much they like coming to the place, and this contrasts sometimes with the views we have from kind of visiting politicians, for example, or who say, well, do you tell everybody they have to stop using when they come to the room? We are funding, we're funding this center, we expect that everybody who comes to the room, you kind of, as they walk in the door, you tell them that they have to stop using. And so, and obviously if we did that, then nobody would want to come at all. But my point is, I get to, is that many people do in fact want to stop using, and that's part of what we offer. But if you look at the other impacts of a facility, the evaluation that we had at 18 months showed that it does in fact reduce overdose deaths in the area when overdose, kind of ambulance attendants for overdose were going up in the rest of the city. But back to the design of this facility, when we were initially consulting with the people who are using drugs in the area, we asked them what kind of service did they want, and they said two things. They said they wanted a one-stop shop. They wanted a place where they could not only inject but also receive treatment and care for hepatitis C and other bloodborne viruses, also receive drug dependence treatment, also receive wound care, oral health care, overdose prevention. And they also wanted that care to be provided by a multidisciplinary team. And what they meant by that was not just health professionals, but also peer workers, harm reduction practitioners, people with a lived experience of substance use disorders. So with that in mind, we've really tried to design a service that is at the same time both a kind of harm reduction service and also a healthcare service. And some of these things overlap and some of them are distinct. If we look at the characteristics of a harm reduction service, it's a low threshold service. There's very few barriers to entry. We kind of try and be friendly to people, give them what they want. It's an anonymous service. You don't have to tell who you are or anything about yourself. On the other hand, healthcare services, we try to provide a safe service. We're trying to provide interventions which we know have a benefit, and we know they have a low risk and certainly a managed risk. There's a degree of medical oversight of the service, and we need to keep medical records. We need to know who people are in order to keep those medical records. But there is a space in between these two, and you can in fact provide services on a continuum where people can kind of choose where they want to be on this spectrum. And some of the things we offer are at the kind of pure harm reduction end of the spectrum, and other services are at the kind of the healthcare end of the spectrum. And people can choose when they want to be, where they want to be in that spectrum. And so that's why we've kind of chose this design here, where on the one hand, it's you can use the facility anonymously as an injecting room client, but at the same time, you can receive a range of healthcare interventions on site. And if we look at some of those low threshold interventions, there's kind of safe injecting advice, even if you're injecting in your groins, which many people do. Obviously, kind of management of overdose training and take home naloxone, food, clothing, housing, legal support, wound care, and obviously non-judgmental engagement of all kinds. And then at the same time, we provide hepatitis C and other bloodborne virus testing, treatment, oral healthcare, kind of pharmacotherapy, mental health support, and kind of range of primary healthcare. And just to give an example, hepatitis C treatment in Australia, while completely subsidized by the government, other than a kind of $6 co-payment, is nonetheless a complex thing for people to organize. They've got to go to a doctor, somebody to take the blood, back to the doctor, maybe a second blood test, have a scan of their liver, see a specialist. It's really complex. And so we've tried to revise the way we do it so that it just makes it easier for people who are kind of happy to have the treatment, that they just haven't prioritized it enough to get through all those steps. But what we can do is we can offer a blood test, a finger prick blood test to people as they walk in the front, or while they're using the injecting room, the blood is being analyzed with a PCR gene expert machine, which takes about 60 minutes. And then after they've used the facility, they have a chat with one of the nurses with the Hep C trained, and who may do a FibroScan while we're waiting for the results to come back, and interview, collect, do a kind of screening interview. And then by the time that's finished, we get the results of the hepatitis test. And if people wait another 20 minutes, we can get them their initial medication. And so that's kind of meets all our criteria of a kind of medical service, but it's done in a way that's easy for clients to access if they've got a lot of other priorities in their life. And so in this approach, we've kind of screened more than 800 people and treated 230. It's now kind of over 300 people with this. We're the biggest hepatitis C treatment provider outside the prison system. But and we can use the same approach to treating oral health care, which again, many people prioritize, but it's just a challenge for them. But by the use of this is a kind of silver fluoride treatment, we can make it easy for people to get that care. And we can do the same for opioid pharmacotherapy. And there was a bit of controversy about this from our staff at the beginning. They thought, is this really the place where we should be offering opioid pharmacotherapy? People, surely they don't use an injecting room if they want to stop using. It's a place where they come if they want to use their heroin. But many people, when we spoke to them, actually, they had trouble accessing treatment elsewhere. They found that there were waiting lists. It was costing them money. They had difficulty attending their kind of appointment-based treatment models. And they didn't like attending pharmacy every day for their dosing. And people started coming to us saying, can we help them to stop using? They've been using for 25 years and they're over it. They don't want to do it anymore. They just can't see how to get out of it. And they find navigating the treatment system overwhelming. So initially we referred to some of the doctors at the community health centre, but they soon said they were full. We tried to refer to other people, but they said they were full too. So we kind of trained some doctors and nurse practitioners and started prescribing on site, methadone and Suboxone. And then when the long-acting buprenorphine came along, we started administering that, and now that's our main model, either the Buvidal monthly or the Sublocade injections. And both of these in high doses will block the effects of heroin although not so much at low doses. But this was really, again, raised the question, is this the kind of treatment that we should be offering to people who use a medically supervised injecting room? But again, we fall back on what the principles of care that we have is really to kind of more what we would call trauma-informed than anything else, to be kind of responsive to what people's needs are. And so in this mindset, it's offering them a choice of pharmacotherapy, kind of being flexible with how we do that within safety limits. And so this has resulted in us using this being the main choice of pharmacotherapy. And people actually request to initiate on day one on the high dose of the injection the most of the time. We did an analysis of our first 40 clients, and much to our, who we treated in this way, and much to our surprise, the majority of them actually went from 10 visits to the injecting room in the month prior to using to no visits at all. So they basically, like they told us, they'd had enough of using, and the majority actually did stop using as far as we could tell in the period of time after they initially injected, and with very positive experiences of it. And so we did a larger analysis of the first 12 months of treatment. Again, they were fairly representative of our regular clients, and they had really major reductions in heroin use, good retentions in treatment, reductions in other drug use, improvements in quality of life, and again, vastly preferred treatment of this injection over their previous experiences of methadone or Suboxone treatment. So what did we learn from this experience? That you know, some people need a kind of pure harm reduction approach without any judgment, but some of those people will be ready to stop using at a certain point, and those same skills that we use in engaging with people from a harm reduction perspective, actually that same approach has proven useful for helping those people transition to kind of opiate pharmacotherapy and also to stop using in many cases. Although that's not always their goal, it's actually turned out to be their goal far more than we thought it was going to be. And I'll leave it there. Thank you.
Great, thank you so much, Nico. That was very interesting and fabulous work you're doing in Melbourne there. So congratulations. Great, next up we have Dr. Sotiris Leanis. He is a psychologist and deputy scientific supervisor of self-help promotion programs in Greece, and also a lecturer at Aristotle University of Thessaloniki. And he will be talking to us about self-help promotion groups in Greece. So with that, Sotiris, floor is yours, and I will share my screen.
I can share my screen, Jenna. It would be
perfect.
Thank you very much.
Good
afternoon or good morning or whatever around the world. I would really like to thank the organizers for the invitation. I have heard two very interesting lectures. I work more than 20 years in the field of addiction, and I'm wondering why all these great ideas do not get into a dialogue. Two approaches, I mean, harm reduction. Do we have the luxury to just to walk to parallel roads, or we have to make a bridge, as I'm saying in my presentation? Let me. Okay. Do you see my screen? That's fine. Okay. There's some information about me and about self-help promotion programs. I will pass them. The structure of the presentation. Firstly, I would like to discuss with you if we have a need to create a bridge between the two approaches. What are the arising problems or difficulties in this construction of a bridge? Then I will share with you some experiences from Greece, from an ongoing project that we are doing here, and I'll summarize my presentation. Okay, What is the field today? A first fact I think that we have to discuss is that opioid substitution programs internationally, not only in Greece, serve the majority of people with opioid addiction problems. What about abstinence treatment programs? In Greece, the situation is this: more than 8,000 people participate in opioid substitution treatment programs, and the abstinence treatment programs offer 1,300.
So Terry, I'm sorry to interrupt. Can you move your slides, please?
Yes, the slides are not moving.
So Terry, just put them on presentation mode and move your slides so we can follow better your.
Okay, I will open the PDF. So now you can see.
Yes, that's fine. Great, thank you.
We're here. In Greece, the situation is this: more than 8,000 people participate in opioid substitution programs, and only 1,300 service users per year are in abstinence programs, and not necessarily all of these people are opioid using people. So we have a great distance between the two approaches. On the other hand, Greece has a very well-established public network of abstinence treatment programs. As you can see, therapeutic communities, hospital-based programs, self-help promotion programs, self-help groups. So we have a lot of experience in both approaches. And this is a fact that we should keep in mind. Another question we should ask ourselves is whether opioid substitution treatment programs can provide a holistic approach for people with opioid addiction problems. To be more exact, from harm reduction to successful social integration. In Greece, and I believe internationally too, substitution programs gave an emphasis on harm reduction. With the decline of overdose deaths in Greece, this is a fact, and the improvement of quality of life in various issues. But they also created the situation of institutionalization for the great majority of people. In Greece, we have the situation that a lot of people attend these programs for more than 10 or 15 years, and this alone is not a problem. The problem is that they do not present significant changes in life issues, and they have limited opportunities to be socially reintegrated. Can abstinence treatment programs contribute to this situation? In Greece, we believe that they can, because they have a lot of experience in recovery and social integration, and they can make a substantial contribution. Having in mind the above ideas, and based on the fact that the majority of people with opioid addiction problems attend opioid substitution treatment programs, the fact that these programs play a crucial role in harm reduction, but there are unmet needs of their members, especially in the field of social integration. The fact that abstinence treatment programs have experience in methodologies oriented to recovery, I think that is apparent that there is a need for creating a bridge, a continuum between these two types of intervention. So why this bridge is difficult to be built? I will present here some ideas with an emphasis to the Greek experience, but I think that we might find commons with other countries too. The first problem is the views and perception of service users and health professionals in opioid substitution programs. You can see the various reasons. The second is the views and perceptions of service users and health professionals in abstinence treatment programs. Let me give you an example. When we've tried the intervention that I will tell you next, the most difficult thing was to persuade the colleagues of the opioid substitution program and the colleagues of an abstinence program to come together and cooperate. Not the service users, the health professionals. Each one has very well-established views and perceptions that the opposite model cannot offer anything. Apart from these problems, we have problems with scientific and institutional controversies in Greece. For example, recovery is the only way, harm reduction is nothing, or the other way. And not only scientific controversies, but we have a lot of controversies from the organization that promote the one or the other approach, because they connect this controversy with the resources that they can get, etc. I think that some very interesting questions arise, scientific questions. Is total abstinence the only legitimate target of recovery? Professor Potenza made some very interesting remarks in his lecture, how we came where we are today, these last 150 years. Can controlled use of substance be a legitimate target of recovery? There are these two questions that are existent in our discussion here in Greece. So the questions, I propose that we should shift the question from abstinence or control use to the questions significant involvement of improvement of quality of life. Or in other words, can a harm reduction approach be combined to an abstinent approach, or at least can it be used in social reintegration? I believe that, of course, it can. Are there benefits of constructing a bridge between harm reduction and abstinence treatment programs? You can see, in my opinion, there are a lot of benefits, only benefits. Improvement of the quality of life of service users, producing new ideas of intervening. Our sciences can be enriched by another, a more close relationship between these two approaches. So what we have done in Greece, we have established a participatory action research project between an abstinence program and an opioid substitution treatment program, with the aims that you can see in the presentation. Why we chose the methodology of participatory action research? Because in a field that we do not know a lot of things, and we need to try new things and ideas, and to have in a very crucial and to put ahead the people that are directly involved, the service users. Participatory action research is a methodology that helps us to do such an effort. So the main steps was needs assessment in a collective way through teamwork, planning of the specific actions that took place in the abstinence program, implementation and evaluation of these actions. We'll see what you will see what I mean. All of these were made in a collective way. We set up some criteria which people can come from the opioid substitution program to an abstinence program. The criteria were set up by the professionals of the two programs. From the three criteria we have set up, the first one was the problematic one, because no one showed absence of parallel use of illegal substances or abuse of non-prescribed drugs. This was a very hot topic for the health professionals in the abstinence program, because they said, no, we were right, no one can continue to next phase, etc. There were some steps that we followed in the project. We started with constructing a group of the interested members. We set up, we started person meetings between health professionals and the member that was interested in participating in our effort. Then we set up 3 initial group meetings that we presented the project, we made the needs assessment, and we documented the ideas and proposals of the service users. There was a preliminary stage of 1 month. 2 groups every meeting. After the completion of the preliminary month, the participants that remained, because some dropped out, continued the formation of individual plan and participation to the abstinence program now, and continue to participate in parallel in the opioid substitution treatment program. Some demographic information. Okay, where the people got into, they received the following services. You can see the services: participation to a day center, support groups, individual counseling, support to various health, legal, educational, vocational issues, etc. The last one, we help them to establish a work integration social enterprise that is still in business and is going very well. The benefits of the participation of this project, as mentioned by participants and health professionals. They said that they were activated and become more socialized. Loneliness was a very big problem for participants of an opioid substitution treatment program. They mentioned improvement on functionality and quality of life, improvement of health, decrease of parallel youth, not absence, decrease. Successful completion for some of them, percentage around 20% completed the opioid substitution treatment program. They acquired skills and knowledge because they participated in a lot of seminars, etc. They improved their social networks and their family relationships. And some of them found work. You can see here some of their own words, what were the basic help mechanisms in this intervention that connected an opioid substitution treatment program to an abstinence program. Compassionate climate, climate of safety, not bureaucratic function of the project. They were, they undermined, they said that it was very important. They were activated and they took responsibility. And last but not least, that the intervention was characterized by a quality of direct access and operation, and the program operated as a stable point of reference. An open door that whenever I want it, I can come to. It's a real challenge to create bridges among opioid substitution programs and abstinence programs, but I think that it's a priority, especially in our country, to try to go to this direction. New scientific questions arise. What is the content of recovery? Which are the main assumptions between popular ideas, for example, sobriety, harm reduction, etc. And a lot of work has to be done with health professionals of all types of programs, education, etc., with the service user of full-time programs, with the society in general, because here in Greece, we have this thing, the abstinence programs were the first programs that were established in the country. So the social representation about what recovery and treatment is came out from this experience. It was a very important experience. And when harm reduction programs were established in our country, they had a negative view that came out, if I want to be sincere, from the professionals themselves. And this view spread to the community, and now they are followed by a negative social representation. This is what I have to say. Thank you.
Thank you, Sotiris. That was very interesting and a nice perspective on a more abstinence-based approach in Greece. So thank you so much. So next up, we have Parnian Rafi, who is a graduate of in clinical psychology from University of Tehran. And she is currently a graduate research assistant and practicing clinical psychologist at the Iranian National Center for Addiction Services, and which is a registered WHO collaborating center. And Parnian is joining the Department of Psychology and Global Brain Health Institute at Trinity College, Dublin, as a PhD student in September of 2022. So best of luck with that. So I will share my screen.
Thank you so much, Jenna.
Oops.
If it doesn't hurt. Thank you.
Okay.
Yeah, so that's the first slide. Yeah, amazing. Thank you so much. So let me bring it up here. So thank you so much, everyone. And thank you for the warm introduction and also for inviting me here, Jenna and Christos. So today I'm going to talk a little bit about the abstinence-based and harm reduction approaches in managing opioid use disorders in Iran and the current situation. So Iran has the highest rate of abuse of opiates in the world. And over 42 global consumption of opium is estimated to be used in Iran. And also Iran consumes 5% of the whole global heroin consumption. Also, the vast majority of global opium seizures, like about 83%, take place in Iran, like the 3/4 of world's opium seizures. Every year, tons of opium flow from Afghanistan to the rest of the world, and the biggest share, that is 40%, is through Iran. Next slide, please. It's a PDF, right? No animations. All right, so I had an animation here, so no worries. So Iran is the second largest country in the Middle East. You may know of the Golden Crescent region of South Asia, comprising Afghanistan, Iran, and Pakistan, which is a a principal global site for opium production and distribution in the world. The Golden Crescent is much older than the counterpart in the Southeast Asia, which is called Golden Triangle. In 2007, the Golden Crescent produced more than 8,000 tons of the world's 9,000 total tons of opium, which is the 80% of the world's heroin, effectively making it a monopoly. Next slide, please. Oh, no, you got the animation. So it is Iran, Iran situation on the globe. Next slide. In light of the, the critical geopolitical situation of Iran as a major transit route for drug trafficking, you can see the traditional Balkan route for trafficking heroin, a route linking Afghanistan to Iran, then passing through Turkey, representing the shortest distance and most direct land route to European consumer markets. This route has been used to traffic, heroin into the European Union since the 1980s. And also there is a new Caucasus route there to avoid the heavily policed Iranian-Turkish border on this route. And that's, the tons of opiates produced in the Golden Crescent are trafficked from Iran to Turkey via Armenia, Azerbaijan, and Georgia. Next slide, please. Since 1997, the consumption of drugs is no longer a capital offense in Iran. It used to be so before the Iranian Revolution. And in January 2018, Iran raised the amount of drugs in possession that triggers the death penalty from a mere 30 grams of heroin, morphine, and cocaine, and 5 kilograms of cannabis and opium to more than 50 kilograms of opium and 2 kilograms of heroin. And since early 2000s, Iran has introduced some of the most progressive practices of addiction treatment and rehabilitation programs in the whole world. Next slide, please. So Iran has, the compulsory abstinence-based treatment programs. Like under some Iranian laws, drug users can be forcibly detained in some centers called detox camps that receive government money for those placements. And those that are referred to these residential centers, most of them, about 90% of them, are admitted following a court order, and they stay in those detox camps for an average of 2 to 6 months. The abstinence rule within these camps, however, is incredibly strict. Like even drugs prescribed for mental health problems are forcibly discontinued on entry. According to several sources, I heard that this has led to many patients there having psychotic episodes during treatment and suffering from severe downturns in their mental health. But these camps, compulsory camps, abstinence-based ones, run a 12 steps abstinence-based program modeled on those run by Narcotics Anonymous, or NA, or Alcoholics Anonymous, or AA. Next slide, please. So this is an overview of the available, drug treatment, addiction treatment programs available in Iran. I'm not going to go through into details for the sake of time, but Iran has one of the largest methadone maintenance treatment, or MMT, programs across the world, with more than 700,000 participants in more than 7,000 outpatient programs active in the country. The first long-term substitution program for MMT was initiated in 1999 by an NGO, and then after that, in 2002, the Iranian National Center for Addiction Studies ran the first pilot project and opened this governmental psychiatric hospital for, methadone maintenance treatment. And as of 2018, about 720,000 community residents are receiving MMT, and 60,000 persons were under MMT while in prison, and over 2,000 MMT centers were opened in the country over past 10 years. And about buprenorphine, it has been approved in 2006 for maintenance treatment of opiate dependence. However, no insurance coverage or government support for buprenorphine program is available. And as of 2018, about 120,000 people were receiving buprenorphine. And lastly, tincture of opium, which is an oral water alcohol extract of opium containing 1% morphine, was first piloted in the Iranian National Center for Addiction Studies in 2006. And since 2011, it is available in agonist units with two different approaches, including maintenance treatment and gradual dose reduction or extended detoxification approach. And as of 2018, more than 93,000 people were receiving opium tinctures. Next slide, please. And this is a figure just to take a look at that. On the x-axis, you can see the years, and the y-axis, you can see numbers. So you can see in 2000 and after 2002 and 2006, methadone programs, triangular clinics, and buprenorphine programs were initiated. The number of deaths due to substance use were significantly decreasing, and also the HIV transmitted through injections also saw a drop. And you can see that significant number of outpatient centers, increasing from 2010. However, the HIV transmitted through sex had a slight rise during all of these years. Next slide, please. This is also an overview of harm reduction services for substance users available in Iran. You can, at the right side, the table shows the coverage and the numbers reported by Ministry of Health and Social Welfare organizations, but you can see that there are drop-in centers available, outreach programs such as needle and syringe programs, low threshold methadone treatment, condom promotion, and safer sex education, as well as facilities for homeless or marginalized drug users, antiretroviral therapy for people living with HIV, and government-supported women-friendly facilities for sex workers with a substance use disorder. Next slide, please. So this addiction paper, published by a team of Iranian addiction scientists and practitioners, has showed that and concluded that Iran has experienced an interesting trajectory in drug addiction treatment programs after the revolution in 1979, and currently there is a new shift toward reducing the severity of criminal penalties for drug use in cells and promoting proposals for opium legalization. Next slide, please. And the last slide. So, but this recent paper from two of my colleagues, Iranian colleagues, Dr. Ali Faroudian and Dr. Ramin Ratfaz, mentioned the dual catastrophic situation for the Iranian substance use treatment services in Iran, surviving the dual catastrophic situation, the economic sanctions imposed on Iran by the US government, and also the COVID-19 pandemic that are, called dual catastrophe, collectively really challenged the substance use treatment services in Iran. One click, please. So, the sanctions after 2018, you may have seen this tweet by Donald J. Trump announcing new sanctions on healthcare system and medication in Iran with this Game of Thrones style image. Sanctions are coming. After that, some of the healthcare systems and clinics for substance use treatment patients were really challenged, but these new changes in the system are being, really progressing over the last years. And now I'm handing over to my colleague, next slide, please. Handing over to my colleague, Dr. Hossein Mahrdasardebili, to just discuss the initiative that is being led by him for investigating the early career practitioners' attitude toward the harm reduction oriented services and abstinence-based services in Iran and also other parts of the world. And thank you for the attention. You can contact me for inquiries and comments, my email and my Twitter account. And thank you for the opportunity.
Great, thank you so much, Parnian. That was really, really fascinating on the state of Iran and their approach here. So thank you so much. So as Parnian mentioned, up next we have Dr. Hossein Mahrdasardebili, who is a psychiatry resident at Mashhad University in Mashhad, Iran, and also the ISAM Next co-chair. So with that, I'd like to hand the floor over to Hossein.
Hi, Jenna. Thank you. Thank you for your kind words and introduction. If I have the actually permission to share my slide, I think it would be much more fluent. If now currently I don't have the permission.
You've got it now. Sorry.
Okay, thank you very much. Yeah. Okay. Please let me know if you can see.
Yes.
Okay. So is it in full screen?
Yes.
Okay, thank you. Okay, let's say hello to my colleagues and friends in this webinar. I'm really glad to be with you as the last actually presenter in this webinar. As you can see, the main topic that I'm going to discuss is actually a short, brief overview of a study protocol aiming to assess the early career psychiatrist knowledge and attitude toward two main approaches in opioid use disorder, treating opioid use disorders, which is harm reduction and abstinence-based approaches. Let me first introduce my colleagues, actually young colleagues of my mentorship team who actually helped me in starting and running this study, Sayyid Kimia Jasemi from Kermanshah University, from actually west of Iran, and Parisa Qasemi, who is psychiatric resident in Mashhad University of Medical Science. Let me have a quick look at the outline of this presentation. We will actually take a quick look at the background of where this title, this topic came from, what were the questions, the gaps that we are going to actually feel and address, an idea for a survey, where did it came from, how did we design, and what would be the steps, further steps and study progresses. The main question come from this actually simple code we may sometimes have with our patients. I myself, I'm a actually psychiatry resident in my third year of actually training, and I have many actually people who come to the emergency room or to my office in the hospital and say, we don't want to quit. We are smoking, we are using opioids, using different drugs, and we currently don't want to quit. So what can we do? Many of us, actually my colleagues, like other actually early career psychiatrists in my university, maybe they answer, so what can we do? What can we do if you don't want to quit? So what should we do? And lots of early career psychiatrists do not have actually efficient knowledge and awareness of what other services are available in the local setting of their actually city or university that can be provided for the opioid users. I will actually may pass these slide, because the impact of opioid and opioid use disorder is, I think, evidence. It has the largest burden of disease attributed to drug use from among other drugs. And the treatments, two major groups are two major category of treatments for opioid use disorder is harm reduction, as discussed before. There are some policies that aimed at reducing behavioral and physical harms. And the other is the abstinence-based that most of us are familiar with, that focuses on stopping opioid usage. Now, what is the main question? Is there enough knowledge about different opioid use disorder treatment approaches among young psychiatrists, and how they choose their treatment approach? What actually is their attitude toward different approaches available? For actually finding the answer, we had a quick literature review in actually available databases. And there are several gaps to answer this question in a global perspective. There are lack of similar and related previous studies, especially in Middle East and in any other and every other regions globally, but especially in Middle East, that we have several issues with opioid use disorder. And there are many region-specific lack of data, and mainly about on actually young psychiatrists. What is their knowledge about this issue, and what is their actually attitude? There are some available studies, but they're different in the main question, in the scope, in the population they have chosen, and in about the region they have done the survey. So we still have lots of gap in this specific field. As discussed before, if we want to actually talk about the gaps more specifically in a selected region, we might have problems, questions about the curriculums and trainings for the early career psychiatrists. Is the curriculum comprehensive enough in this term? do the curriculum actually, does it provide a region-specific knowledge about the services available? Is it actually provided with efficient practice or not? And the other actual aspect is the healthcare system aspect. With does the healthcare system provide appropriate local protocols, and are different treatments available in the local setting or not? And what about the public awareness? Do we have actually enough awareness among the public about the services available and the treatments that can be reached? So we aimed to assess the knowledge and the attitudes of early career psychiatrists toward these two major treatment approaches in treating opioid use disorders. We actually decided to start this survey from Iran, as you know, and as Parnian said, it is has the highest rate of opioid use globally. Is actually neighboring Afghanistan, the major producer of opioids. And this interesting thing is that we currently do not have a specific established fellowship in addiction medicine. It will going to be happen in following months for the first time in Iran, but now currently we don't have such a fellowship for addiction medicine. And then the next phase will be actually the global phase, that we can actually plan to use the potentials in ISAM-Next and NECPAM initiatives that are international actually associations for early career addiction medicine psychiatrists. Okay, the steps that we have actually designed for this study, as you see, is shaping the primary idea of which this specific webinar, especially actually the topic that I am presenting, was the main main start of the study. We created a team. We are actually sensitive to use call and collaborate with undergraduates and postgraduate students and involve them in the process. So we created a team and did initial research to make the idea more mature. And then the comprehensive literature review to find similar studies and questionnaires. And then we started to develop our own questionnaire to address our own questions and gaps. Now we have the first sample of the questionnaire developed by our undergraduate, postgraduate team, and it is ready to be revised and checked by addiction experts. It is the next stage of this project. Then it will be the questionnaire will be finalized, validated. The pilot study will be done in Iran in 3 centers: Mashhad, Kermanshah, and Tehran. And then we will look for linking persons globally among NECPAM and ISAM-Next initiatives. And the international phase will be run. As you see, the questionnaire will be is shaped in 4 major parts: demographics, local info, which is talking about asking about the curriculum and the available services locally in each city and in each university that the responders come from. Then it will focus on knowledge assessment about these 2 main approaches, and finally, psychiatrists. I would be really glad to have linking persons and collaborators, colleagues from different parts of the world for our second phase of the study, which will be done in 2-3 months from now, hopefully. So I would be glad to have colleagues sending me email, and we will be in touch to for the next stages. That's it. Thank you. Thank you very much for listening to this talk and attending this webinar. Jenna, please go on.
Thank you so much, Hossein. That was really, really interesting and really important work that you're doing with undergraduate and graduate residents. So we look forward to hearing your results from the questionnaire, and hopefully we can, acquire some collaborators from this webinar. So thank you so much. So with that, we'll open up to some questions for from the participants, and I hand that over to Christos.
Yes, and it's my turn to thank all the presenters, all the speakers for the very interesting presentations. We have one question on chat from Richard, and I suspect that is a question to Nico, if there was any opposition to the supervised drug consumption room, and how did you overcome that one? And a secondary question, the same subject, what about the capital and the recurrent costs of the center? Very specific to the supervised consumption room. So Nico, if you have a response to that, then I can see another question coming from Norman. Nico?
Yeah, so there, it has been and remains very controversial. The way that those kind of challenges have been managed has changed since before opening the injecting room and after. So before the room opened, the main vehicle was family members who had lost their children to heroin overdose, calling for some change, and they were family members are very effective in kind of getting sympathy for the issue and convincing various institutions and politicians and even ultimately media outlets that something should be done rather than letting our young people die of heroin overdose. And that was really, it was the kind of through this kind of grassroots activism, largely led by family members and people living in the area where people were overdosing, and supported through the harm reduction organizations, and then ultimately as some politicians that came on board. Once the facility is opened, there it shifts a little bit, and the main opposition then comes from the people in the immediate vicinity of the room, who are threatened by the presence of it. And again, not all, but just some people who live in the near vicinity find it the presence of drug activities which have been ongoing for many years normally becomes an opportunity to get negative media. And then people who are ideologically opposed, like conservative media outlets and politicians, then kind of jump on this and magnify it, and that's an ongoing discussion. But the more information has come out about the nature of the struggles that people face when they're using the facility, and how they're getting support of different kinds when they use the facility, the more public support there is for the service. The model we have is not cheap, and the government has kind of announced that it costs several million a year to run such a facility, but it's both a healthcare facility as well as a place for people to inject.
Thank you, Nico. We have a discussion, a question from Norman. I suspect I need to unmute. Norman, can you, yeah, great.
So I'm Dr. Weatherall. And I can't remember who the first speaker is, I'm sorry. It's not really a question, but he's going to want to reply to it, I'm sure, and should. I've been involved, actually I spoke at the ISAM conference a couple years ago on the changes in terms of views of drug users and the idea of abstinence and the disease concept. And I think in terms of the history, we need to in this whole thing, and I'm for harm reduction very much. I helped ASAM do their policy and injection sites, which includes making sure they have access to other treatments. But in any case, as we move, trying to be more open to people and listen to where they're coming from, which is I think we all agree is important. We have considered this to be a disease, and so the first speaker there, that's an important thing. So if it's a disease, brain disease, then it's not you're not totally responsible for everything, and we offer you treatment, and we understand that this, there was a certain, I'm not going to say insanity, but a certain amount of things that you didn't plan to do. Now, what's happening now is this getting away from the idea of abstinence. And obviously patients have to choose what they want to do. But I know that where we are in New York State, they really do not, whatever the patient says is just fine. And if you think of tobacco, telling people to cut back, they're not going to be able to stop. And we struggled with this with alcohol for years. People that are going to, and sometimes people are successful, but we still have the concept of disease. And I don't hear that mentioned as much. And so I'm concerned about that. Also, my presentation before, the Society of Drug Users, they have a statement, they don't want to have this called a disease. They think it's demeaning. And to talk about prevention, it's demeaning. Why? What are you trying to prevent? So I'm not saying they all say that, but there was a slide I had that. And I think that it's hard. We don't want to have stigma, and we want to people to come in and feel free. And I think that's good. But we have to also, in terms of your history of addiction, how do we have the concept of disease? We want to still continue the concept of disease. It's gonna, we're asking insurance companies to pay. We're asking people to not go to jail. This is a disease, a brain disease, and so we're going to send them into treatment and see if we can help them, and so forth. So I'm just concerned about going forward how society would say, and how we feel as addiction specialists, and in different countries. Is this a disease, a brain disease, and that you really and you need to substitute or stop or something if you for best chances of getting better. So, I mean, there are exceptions, of course. In any disease, you have people that don't get cancer with chemotherapy and they get better. Is it a disease like that, or is it not a disease like our other diseases? Not a medical. We only treat the complications, and we do not see this is a brain disease. Okay, so I'll let people comment.
Yeah, so I think that was directed
Marc, yes.
towards me as the first speaker, and thinking about how the conceptualizations and the core features of addictions have changed historically. And the notion of addiction as a brain disease is one that has been forwarded for many decades. And I think going back to the 1990s, the directors, for example, of NIDA really made a big push for understanding the brain mechanisms underlying substance use disorders, and I would argue addictions more broadly. And I think that this is a really important aspect because yes, there are brain regions and networks involved. There are also important social and environmental aspects, some of which may importantly influence some of the brain networks and regions that are implicated in addiction. And substance use itself, or engagement in addictive behaviors, may also influence brain structure and function in ways that may perpetuate or lead to recovery from addictions. So I think it will be important for us to listen to the different perspectives. I personally believe that brain mechanisms are really important with respect to considering addictive behaviors and disorders. I think that in the talk that I gave, I did discuss how the disorders and how they've been defined, and I did this only briefly given time limitations, have changed over time. And I think with respect to people's motivations for change, that has been also a focus of a lot of research, both at individual levels and at disorder brain-based levels and in other domains. So this is complex. I feel that we do need to be mindful of how people are describing their lived experiences. And I would also highlight that in talking with people with lived experiences, there is a heterogeneity within that group as to how they conceptualize their lived experiences with respect to consideration of a disease or disorder, and there are varying views. So it's complex. I think it's not unique to addictions, but addictions do have this historical grounding in morality that perhaps some of the other psychiatric conditions may not have quite as fully. But I would also argue that stigma is important for other psychiatric conditions. So I'm not sure if I addressed the question or if I'm just furthering a dialogue from a high level view, but I would be interested in other people's thoughts.
I think you addressed. Go ahead.
Any other thoughts? I have some thoughts to share, but I don't know if it is my place to share my thoughts. If I'm allowed to say, it is very interesting that Norma, the dilemma that your approach in disease or no disease, but I have to say that historically, the concept of disease was very useful for us to move away from the morality issue and gave us grounds to approach the problem of addiction from a different perspective and advance research and treatment. I wouldn't link necessarily stigma with illness or disease, because the stigma has to do with choice. People don't, if there is stigma, people are deprived from the choice to have access to treatment or help. So there is no conflict between stigma and disease, because someone who might have a disease like cancer, we might link the having cancer with a behavior that had chosen or she had chosen to do for years, like smoking, but that does not negate that they have a disease and then they have the choice of having specific treatment or not. A lot of people have cancer and they choose not to have treatment for, or the treatment that we offer for them. The concept of disease is very much linked with the concept of losing control. So from that point of view, is a useful concept, but not having control over something, that does not necessarily mean that it is a disease per se. So what is important, and the point of this webinar, is that dialogue is important, scientific dialogue, where everybody approaches the concept as we don't know the truth, we are approaching the truth. And as long as we enter any concept with this attitude of open-minded, discussing, accepting, trying to find the common space, despite the differences, I think we are on a good path. What has compromised us over years is that false dichotomies and polarization. Is it this or the other? Could be both, could be far more complicated than yes or no. That's my approach. Nico has something to say as well, and I will stop here.
Yeah, I think that the disease concept has been useful in some ways for us to kind of legitimize the kind of healthcare responses to people with substance use. But From our client's perspective, it has a couple of significant limitations. The first one is that it puts the problem on them for when many of them are in fact been, their decisions around substance use have kind of have been, if you like, contributed to by other factors, the kind of the circumstances in which they grew up, often the kind of the traumatic events that they may have witnessed or been experienced when they were younger, and all of these things are in a way negated when we say, well, it's a disease that's going on in their brain. It's nothing to do with anything else, anything that anybody else might have done to somebody, or any other problems in our society as a whole. And then the second way which our clients don't like it is that many people feel that they actually have pretty good control over their substance use choices, and they're labeled as having a disease just because they are in fact, they like using substances and they're just not so afraid to do something that's illegal as other people. And for this they get a label as having a brain disease, when in fact they've just, for whatever reason, they've kind of discovered that kind of certain substances offer them something that they like, and for many of those people, even like many of the people who use our facility, they're not using every day or necessarily in a way that's out of their control. So I think it has kind of served to kind of get healthcare for addictions on the map, but I don't think we should lean on it too much because it has significant limitations.
Thank you, Nico. So Dries wanted to respond. Is that right? And then we'll go to Peter.
Just want to share with you one thought that we have here in Greece, how to overcome this dilemma. We say that it's probably difficult to have a consensus whether it is a chronic relapsing disease or not, but we can easily agree that it is a problem with chronic consequences. So we start dealing with the consequences, and we put at the center the people that are suffering from addiction. And this is a way that the health professionals from different point of views can cooperate without entering the trap of very strong controversies. Thank you.
Thank you. So Peter, yes, please.
Yeah, so I view this disease, it's sort of a distinction without a difference. The whole disease argument. We call it substance use disorder. It's a disorder. But in order to meet criteria for this disorder, you have to sort of have the consequences of it. And early on, substance use is silent. And you're right, there are no, patients don't perceive any harms or any problems from it many times. And the way I think of it is sort of the way I think about high blood pressure. High blood pressure is silent for many, many years. It's a risk factor. It is really what it is. And we're addressing the risk factor. We can argue whether or not hypertension is a disease. It's clearly a disorder because the blood pressure is out of a range of normal that has been established as safe. So clearly there is a range of substance use from risk level, from low levels with very little harm to risky levels to levels that produce harm at different degrees, right? If you look in the DSM, the modifiers are, mild, moderate, and severe. And most of us, I think of severe as addiction. And when we talk about addiction as a brain disease, that's really what we're talking about. But when you think about the disease model, it doesn't really encompass all of the sort of the whole range of risk associated with the disorder. So that's sort of the way I've chosen to think about it. There is, I think, at the extreme end of the spectrum, there is the extreme loss of, what Nico is, I think is Nico who described people who don't view it as a problem and can control their use and whatever. That may not be a disease. That may just be a risk factor for potential consequences and harm. Blood pressure is silent until you have a stroke, right? And the same with this disorder. So I hope that's useful in helping us sort of think through this.
Thank you, Peter. As we're approaching the last 5 minutes of this webinar, very useful comments from Norman about disease, no disease. But the topic of the discussion today was harm reduction versus abstinence-based approaches for something that might be a disease, might not be a disease, might have been a moral deficit or might not be a moral deficit, but definitely we observe a polarization within the treatment we provide for something that might be disease or not. Nevertheless, the question is, how should we approach those dilemmas? And in science, we have plenty of dilemmas. And as we have seen from all the presentations, a common ground there that the attitudes that we have as professionals involved in the field influence the attitudes that societies will have, from the part of the society which is immediately influenced by the problem, the families, and they are very much entitled to have strong views, the neighborhoods where mostly people who are using drugs and they're homeless do use challenges, or the views that the wider society might have that can influence the choice of the politicians that they will choose to govern them. And we have seen on the chart that George, for example, has lost his election in his constituency to a different politician who was advertising toward a different approach for alcohol. So if it is about us, the professionals, not allowing ourselves to get polarized, not allowed ourselves to lose the focus of what is science is about. And I think we need to remind ourselves that science is about relative truth. It's not about absolute truth. Religion has to do with absolute truth. But when we're dealing with science, we know what we know now. And whatever we know now might be proven wrong in a year, 2 years, 3 years. So if we keep that relative knowledge as our weapon or as a tool to approach a problem, I think we'll be in the right way. Otherwise, potentially, we can easily be misguided by politicians who have different agendas, or who might lose track of what is truth or not truth. Hold on, there is what is this new message here? We have a message from Richard. Thanks for interesting presentation. Refusing to be polarized as a distraction from personalized approach to each other. I think that's Richard and captures exactly what this seminar was about. The challenge is too big, the challenge is too complex, the challenge is evolving, and we need to be open-minded, listen to each other, and try to find the common ground, while at the same time allowing for pluralism and a synthetic approach of different approaches. Keeping that in mind, I would like to thank you all for participating in this webinar. I hope that we'll see you all in Malta, either in person or through the internet and different forms. What else? Let's support the project that Hussein was talking about, and let's keep up the network and the discussion. I would like to thank Panian. I would like to thank for the technical support, even the last minute of this webinar. All the presenters, Marc, Nico, Sotiri, Panian, and Hussein. Jana, the last word from you. Thank you.
Exactly what you said. Thank you to everybody who participated and who joined, and hopefully we'll continue this discussion going further.
Yeah, and can I just add something? So as I mentioned before, this was entirely video recorded. So ISAM has a Twitter account and a YouTube channel. So I'm just putting the links in the chat box, and for keeping up with ISAM news and all the webinars and stuff, you can just follow ISAM on YouTube and also Twitter to be able to watch the videos in the recorded webinars. Thank you.
Thank you all. Thank you and goodbye. See you soon. Bye-bye.
Goodbye.
Bye. Thank you. Thank you for the invitation. Bye-bye.
Thank you.